I'm going to be talking to you on neuro-ophthalmic visual fields, basic and interpretation. So what is the role of fields in neuro-ophthalmology? It's a specific anatomy of the visual pathway, and this allows topographic localization of the visual field defects. And this can be ideally picked up using the Goldman kinetic perimetry or the automated static perimetry, which is now in vogue, and this is what I shall be primarily discussing. So let's understand the visual pathways. Now, this is the left visual field and the right visual field. And what we need to understand that anything that enters the retina is basically causing an image which is inverted and reversed, which means the nasal field is getting projected on the temporal retina and the temporal part of the field on the nasal retina. Now, from here, the axons of the ganglion cells form the optic nerve, which reach the chiasm and then develop into optic tract. Now, what you will notice that the temporal retinal fibers, they go along the optic nerve chiasm and continue into the same optic tract, which you will see on both the sides. But the nasal retinal fibers on both sides come to the chiasma and cross over. That means they go onto the opposite tracks. And that is very important in neuro-ophthalmology and will help us diagnose most of the field defects. Once these axons form the optic tract, they finally synapse in the lateral geniculate nucleus as shown, and then from here arise the optic radiations, which finally reach the primary visual cortex. Now, what we need to understand at any level of these, as mentioned, from 1 to 8, if there is any problem or any damage, you are going to get classical visual field defects as is seen here from 1 to 8. And my talk today is going to be, if you look at such field defects, how do you pinpoint where the damage is? Now, unlike glaucoma, where we just look at the optic nerve head and the field, in neuro-ophthalmology, we need both the fields side by side. And this is very important for our PGs and students, that if somebody gives you a defective field in one eye, always ask for the other field, because you need to compare them. And how do you place them? The right eye field has to be kept on the right side and the left eye field on the left side. And this can also be compared by looking at the blind spot. Now, remember, whichever field test, you always have to check that the reliability parameters are perfect. The patient should have good reliability, the pupil should be adequately dilated. So look at all the parameters and also gaze tracking. So unless the fields are perfectly normal and reliable, in terms of reliability, normal, you cannot interpret. So the same application of fields you would do for glaucoma is to be applied here. The other important thing that we should understand, that in neuro-ophthalmology, we look at the grayscale. I mean, this is what we primarily look at. Very rarely the pattern deviation also, which we don't see in glaucoma. So let's move on and see how do we interpret them. Now, this is what I call the power of 6. 6 important questions which will help us reach the diagnosis. 1, is the field loss unilateral or bilateral? If it is unilateral, we're looking at a lesion anterior to the chiasma, or bilateral, we look at, as I'll show you in this diagram, which is the same visual pathway. Note that in a defect, which is involving one eye or unilateral, it's anterior to the chiasma as seen number 1. But any defect which is bilateral is going to be prechiasmal, chiasmal, or posterior chiasmal. That's very important. And thus you know where exactly look for a defect. Now, second question is, does the defect respect the vertical meridian? If it does, it's a chiasmal or posterior chiasmal lesion. Let's look at a diagram again. These are the defects only from 3 to 8 which are respecting the vertical meridian. And if they do so, look at lesions from number 3 to number 8. And if you see number 1 and 2, these are involving the entire eye. They do cross the midline. They go on to the other side. So these will be lesions anterior to the chiasma. Now, the third important question is, what is the pattern? The pattern means what is the type of defect you're getting. It could be a central scotoma only involving the central part, a centrocecal which is involving the blind spot also, a paracentral as seen here. It could be altitudinal. Here, the defect respects the horizontal meridian. An arcuate as seen here. This is a superior arcuate scotoma which you can get. And a classical neuro-ophthalmic field defect is a hemianopic field defect, which involves the field either to the left or right of the point of fixation, as seen here. However, it does not cross the vertical midline, which is what you should understand. The other important specialized hemianopic field defect is a quadrant anopia, as seen here, between the vertical and the horizontal midlines. Then the fourth question, if the defect is bilateral, is the defect homonymous? What do you mean by homonymous? Look here, the right side field defect is temporal, the left side defect is nasal, which means it is on one side of the field. These are posterior chiasmal lesions, as I will explain further. But when you have a defect, you have to know which side it is involved. Like in this case, it was right-sided. Why? So let me explain. These are defects from 4 to 8, which are basically homonymous hemianopic defects, which means the defects are between, as mentioned, between 4 to 8, below and beyond the chiasma. These are left-sided. So when you have defects left-sided, note that the actual defect is in the brain, in the right optic tract or the right optic radiations. Hence, a left-sided defect, if you know the defect in the brain is on the opposite side. So that's important. Now let's differentiate what is an optic tract defect from an optic radiation. You know that what is the difference? The fibers from the optic tracts are going to synapse into the lateral geniculate nucleus, and from there arise a radiation. So it's the LGN which will differentiate the two. So let's look at the optic tract lesions. You will see that the lesion is number 4, as mentioned here. These are incongruous defects. Because this has not yet synapsed, the fibers are coming from the retina, you can get an RAPD and a classical band-shaped optic atrophy, which you can get in these patients, which is on the contralateral side. So when you have a defect, you will find specifically in retrograde, you will find that the optic nerve also gets involved. So that's one way of differentiating. Unlike 5, 6, 7, 8, which are related to optic radiations, where you don't find any changes happening on either the pupillary changes or on the optic nerve head. So let's look at number 5. Number 5.
Madam, can you unmute yourself again? Madam?
So here, these are left-sided homonymous. This is left-sided homonymous hemianopia. And for that, if you notice that the actual tract involved is on the right side. So it could be a right optic tract or a right optic radiation. Now, how do you differentiate between the tract and radiation? Now, you need to understand that it's basically the lateral geniculate nucleus is the one which differentiates the two. The optic tract fibers are still those coming from the retina, which finally synapse here. So this is the way to differentiate by looking at your field defects. Like this is an optic tract defect, which is at number 4. And those defects will be incongruous. You will have an RAPD, that's a relative afferent pupillary defect, because the contralateral optic nerve will be affected in these cases. And a classical band-shaped optic atrophy is seen. So this is a classic appearance in optic tract. Now in optic radiation, which is number 5, 6, 7, 8, you will find no changes in the pupillary effect, that is a light reflex, or also on the optic nerve. And that's the way to differentiate. Now let's move to number 5. As seen here, these are basically the Mayer's loop, which are inferior radiations which get affected, and classically a superior incomplete homonymous hemianopia develops. And number 7, as seen here, where you have basically an inferior quadrant anopia or a hemianopia which is incongruous because of the superior radiations. Now these are classically features which you get in the temporal lobe or the parietal lobe. The temporal lobe is a pie in the sky, which is denser superiorly and has the classical temporal lobe neurological signs. Parietal lobe, on the other hand, is a pie in the floor, which is denser inferiorly, and the parietal lobe signs and hemiplegia and other things specific for the parietal lobe. Now, what are we spoken up to now is about homonymous hemianopia, which means to the same side the defect is. But what is heteronymous hemianopia? What you notice here, it is the same field, which in this case is a bitemporal hemianopia. Both the temporal fields of each eye are involved. And when you have that, it is only a chiasmal tumor involvement. Like in this case, you can see the tumor pressing on the chiasma, you get a bitemporal hemianopia. So now we've already reached the site. So one important question that we need to finally ask is the defect congruous? Because the more congruous it is, the more posterior the lesion it is, we are looking at the occipital lobe. So what do you mean by congruous? Let's first see what is incongruous. The defect of one eye does not exactly resemble that of the other eye in shape, extent, and laterality, as you can see here. There's a difference. But in congruous lesions, The field defect on one eye greatly resembles that of the other eye in shape, extent, and laterality. That's a classical congruous lesion, and what we are looking at in that case is the occipital lobe lesions, which I shall explain. When you have an occipital lobe lesion, you can have four types. One, as seen here by 11, which is a classical homonymous hemianopia, highly congruous, with a temporal crescent preserved because that has a monocular representation. It could be 12, where the tip of the occipital lobe is involved, which has only central lesions as seen here. It could be a macular sparing homonymous hemianopia, which is highly congruous because the vascular supply to the tip of the occipital lobe and the calcarine cortex is different, so that way it's spared. And finally, only the temporal crescent involvement, which has a monocular representation. Now, how would you finally write this interpretation? One, side of the defect, right or left. Quadrant anopia, whether it's superior or inferior. Hemianopia, complete or incomplete. And if incomplete, whether it's denser superiorly or inferiorly. Congruous or incongruous. Macular split or not. Central or not. So this is how you would write your field. However, there are exceptions to all. Like, for example, you may have bilateral altitudinal congruous defects, which is very common in occipital lobe lesions. Like in this case, superior altitudinal defects is due to bilateral infarcts of the inferior occipital lobe. You could also have bilateral peripheral constrictions that's seen in IIH or occipital lesions. This is an occipital lesion where you can see due to injury to the anterior calcarine sulcus. And in this case, specifically to IIH, I'll just explain to you the first defect in IIH starts with an inferior nasal step as seen here, and this patient presented in 2009, which starts increasing and eventually, like in 2011, develops a constriction. So that's what I was trying to show, that you can develop a constriction, which is seen here already constriction, which starts increasing and ultimately the patient loses vision. So this is a classical example of bilateral constrictions in IIH. So let me now try to explain you with cases. What I would do is, since it's not interactive, the way I am thinking, I would like you all to think in the same way and try to be at the same level, so you will also be able to reach the diagnosis. Again, 6 important questions, and I'll repeat them so that they get fixed in your mind, so that whenever you look at fields next time, you know how to apply. Again, first question, is the field loss unilateral or bilateral? What is the pattern? Does it respect the vertical meridian? If bilateral, is the defect homonymous, and then which side? And is the defect congruous? So let's look at this case. Yes, this is bilateral. Pattern is quadrant anopia, which is basically inferior and respecting the vertical meridian. So we have a left inferior quadrant anopia, which is pie in the floor, which we have discussed. Hence, it's the right parietal lobe lesions because it's the superior radiations involved affecting, giving the inferior opposite field defect. Let's look at case 2. Here we can see both the field tests put, but it's involved only in one eye. When it's unilateral, we are looking at anterior to the chiasma. You can see it's the left eye with less vision, an arcuate scotoma. Therefore, we go back, look at the nerve carefully. What we notice is a pallid disc edema. Obviously, in this situation, you would have picked up the nerve before you go on to the field test. And remember, whatever we do, it has to be correlated ophthalmologically with all your retina, optic nerve, other findings, and neurologically with your MRI scan. But just for your understanding, I wanted to show you, if you keep both the field tests together, you'll notice that because it's involving one eye, we are looking at anterior to the chiasma. Now, this patient was actually a teenager and it had a pallid disc edema, which is very, very rare in children. So this was an anterior ischemic optic neuropathy. So we got this child investigated, and what she actually had is Takayasu arteritis, which is a very rare condition. And this was the first time we reported it as a patient who also had a tonic pupil and anterior ischemic optic neuropathy in a teenager. So in 2013 Canadian Journal. So why I wanted to also show you is, at the same time, the right eye was perfectly normal. If you see, it was 6/6, a normal disc, normal color vision, healthy, and you could make out that the right eye field defects is perfectly normal. But she came in May 2014 saying that the vision was less. Yes, it had dropped from 6/6 to 6/9 parts, but still there was not major disc changes or any color vision changes. But when we did the field test, if you can notice that there was a new defect that came in. This has now a centrocecal defect. And the child was smart enough to pick it up immediately. So before actual ischemia developing into the nerve, she could pick it up. Now, this child was, because of the IR2 arteritis, which is a common feature of Takayasu arteritis, she was awaiting surgery. She immediately underwent the IR2 ICA bypass, and within 2 months, you see that it disappears. So this is an example of early ischemia. So in this case, ischemia like an EIM can also present like a centrocecal scotoma, not necessarily an altitudinal. But what I wanted to highlight here is that the patient is saying there's a problem. All you can pick up is only a mild change or decreased vision. Please do a field test, because that will at least tell you where the problem is, which you can see reverting back because it was in the initial stages. Let's look at case 3. A patient, 52-year-old male, having 6/6 vision in the right eye and 6/12 in the left eye. But looking at all the presentation, you know it is basically temporal fields of both eyes, so classical bitemporal hemianopia. When you have something like this, you have to go back and look at your optic nerve. Your optic nerves definitely would be involved in the later stages, not early, but this patient had a temporal pallor in both eyes. And what we had is, when we did the MRI, there was a pituitary adenoma. So very a field test can pick up early. Sometimes your disc can be perfectly normal, and if you don't do a field test, we are going to miss there's a problem, because once you know this field test, we do a MRI, we can immediately get this surgery done earliest and revert back the fields. Again, let's look at case 4. This is basically bilateral, so posterior to the chiasma. This is quadrant anopia, which is respecting the vertical meridian. It's homonymous, that is right-sided, so right superior quadrant anopia, which is a right pie in the sky, and therefore we are looking at a lesion which will be opposite and inferior, so left temporal lobe lesion. Now, this patient, when we presented, he did not have major symptoms here because this was in the upper part of the field, he had missed it. But when we got his MRI done, what we noticed was these CSF spaces, which are called as Virchow-Robin spaces, which was causing the field defect. It was permanent, it does not resolve, and you don't need to do any surgery for this. We had reported this in Neurology of India as first time any CSF spaces producing visual field defect. This was in 2014. Let's look at case 5. Now, this is bilateral, but you may have to look at each case carefully. Bilateral with central scotomas, which is seen here, but not respecting the vertical meridian. Hence, we go back and look anteriorly, go back and look at your fundus carefully. And when we looked, we realized there is definite temporal pallor in both eyes. And if you look at the macula, it's not looking very healthy. And FFA done thereafter confirmed the presence of a bullseye maculopathy. And this field test was classically related to that. Number 6, this is actually an octopus field done when the patient came. But what you can notice is you're looking here, therefore, at the pattern deviation. And what you are seeing, it's a bitemporal hemianopia, incongruous, but which is denser inferiorly. Now, in case of bitemporal hemianopias, you have to look at denser inferiorly or superiorly because the diagnosis changes. If it's denser inferiorly, we are looking at a pressure from up, and that is a craniopharyngioma. So this patient was diagnosed with craniopharyngioma, underwent surgery for the same, and you can see within 3 months it's resolved. Now, he was on regular follow-up, but 4 months later, he came back saying there's a discomfort in the left eye. He was worried, is the tumor recurring? Because in craniopharyngioma, you don't remove the tumor, you just decompress it, so it can grow again. So when we did the check, the vision was perfectly okay, the disc was normal, the color vision was normal. But if you look at the field defect, you're seeing a nasal defect. Now, we are aware that if you're looking at a recurrence of a chiasmal tumor, we should be expecting a temporal. So I wasn't sure. I felt, was this a recurrence or is it something else? The patient is developing glaucoma, though the pressure was normal. So we said we should keep him on regular follow-up. So we called him 3 weekly and see what happens in 3 weeks. What he has now developed is a classical right incongruous hemianopic scotoma, which we know if it's an incongruous hemianopic and the optic nerve also involved, we're looking at a left optic tract lesion. So there's a left optic tract lesion which is seen. So why that happens? Now here, the chiasma is the tumor, but it has grown and overgrown in such a way that is now pressing on the tract. So these kind of changes can also happen. You should be aware of it so you can follow up them properly. So what are the indications of doing visual fields? 1, diagnostic, unexplained visual loss. Following trauma, chiasmal injury, very important. Like for example, this patient, after having a road traffic accident, lost vision in one eye. He was PL negative. The other eye was 6/6. In that case, you have to do the field test of the good eye to know whether there's a chiasmal injury. Like this patient had an injury, if you can see, that's a chiasmal injury. So that you know that now vision is so very limited. This is very, very important. For any optic neuropathies, neurologically for intracranial tumors, following head injury, in presence of papilledema to follow up and to check for resolution, before and after neurosurgeries, important follow-up for resolution, progression, and recurrence of disease that affects the visual pathways, including the optic nerve. So these are the specific indications. So how would you interpret them? Yes, if it's a unilateral or bilateral, and if it's unilateral, look at the defect. It could be central, centrosequence, paracentral, that could be anything. But altitudinal, think of ischemic optic neuropathy. Arcuate, think of glaucoma. With peripheral constriction, IIH, they could be pre-chiasmal where you see a junctional scotoma. Like for example, coming back to our diagram, if you see position 2, just before the optic nerve enters the chiasma, you will see this classical defect where one eye is completely damaged, but the other eye, you see a peripheral defect, and that's the conjunctional scotoma, for which it's important to do a peripheral field also. The other important pre-chiasmal feature is a monocular scotoma of Traquair. Let me tell you, describe the same by a case. A 62-year-old lady complaining of visual loss came. She was on treatment for hysteria, had undergone ECT for the same. Visited multiple ophthalmologists, was on glaucoma medications also. So if you look at it, there was not major gross changes. The cup disc ratio was also symmetrical. But when we did the visual field defect, we noticed that there's a defect involving only one eye. So when a defect like this is there, first thing that comes is this hysterical blindness or is it true organic disease? And we know she was anyway on treatment. But coming back to what I have been describing, we notice that this defect is respecting the vertical meridian. So in case of hysterical defects, you would find that will not respect the vertical meridian. You'll find bilateral and then they attempt to cross across the midline. Somebody would not be able to actually make a field defect like this, which is respecting the vertical meridian. So we went back and looked at the discs and noticed, yes, there is some amount of temporal pallor. So we cannot avoid that. And hence, keeping that in mind, assuming this is a chiasmal problem, we went ahead and you see the classical snowman type of tumor, which you can see in the sella. This is basically a pituitary adenoma. So the patient was actually having a problem and she was being treated as having some other disease like hysteria, etc. So this is important. This kind of defect is called as a monocular hemianopic defect of Traquair, where only the crossing fibers of that eye got affected and therefore he will have the defect only in one eye, as seen here. So when now coming back to the visual field defects, which are bilateral, to simplify, it could be heteronymous or homonymous. Heteronymous defects are bitemporal hemianopic defects. If denser superiorly, we're looking at a pituitary adenoma, as I said, because this arises from down, presses downwards, causing defects superiorly. If they are denser inferiorly, then we're looking at a craniopharyngioma. Bilateral homonymous defects, on the other hand, could be superior defects and inferior defects. If they are superior defects, they are temporal lobe lesions or a pie in the sky. Inferior defects are actually parietal lobe lesions or pie in the floor. And more congruous lesions are basically, as you go more posteriorly, occipital lesions. What test should we order? If it's a central lesion, look at 10-2, 24-2, or 30-2. Peripheral lesions, you're looking for constrictions or junctional scotomas. As I showed, you need to do a full field 120. If you're looking for drug toxicities like ethambutol, you can do 10-2. If you have a red target on white backgrounds. And functional disability, somebody who has really poor vision, you can do binocular tests as mentioned here. Let me end by showing you two interesting cases in a real scenario to show the power of visual fields. This was case 1, was a 36-year-old gentleman, known case of tuberculosis on AKT, had history of seizures under treatment with the neurologist, history of hypertension under medication, and was referred for blurring of vision in both eyes. If you see, the vision is absolutely okay, 6/6 N6 with normal color vision. Even the fundus was perfectly normal in both eyes. So there's no problem that really could figure out what was the issue. Second, a 29-year-old gentleman wearing glasses since 5 years, with a blurring of vision in left eye since 1 month. This was the vision. It was 6/6 N6, perfectly okay. IOP was also normal, and the fundus looked grossly normal. So we have two situations like this where the patient is actually reading the perfect Snellen chart. So where's the problem? There's something that we should remember here. The patient is always right. And whenever we are not able to explain before advising major tests, just do a simple visual field testing. And that's very important. So let's go back and see what did we find in this. Now, case 1, we found that this patient had bilateral defects similar to what is seen here, whereas case 2 had a similar defect but only involving one eye. So this cases I have shown to show how a similar presentation in a unilateral and bilateral case can make a difference. Again, the same questions that we asked. In this case, is the field loss unilateral or bilateral? Yes, for the case which is involving one eye, it is anterior to the chiasma. For bilateral, it's case 1. Does the defect respect the vertical meridian? Yes, for both of the cases. And what is the pattern? We found central. So coming back to our cases, so case 1, we have a central defect, bilateral, so it's a posterior chiasmal lesion. So now we know that in this case, we have to go beyond the chiasma. We need an MRI to see what the problem is. In case 2, on the other hand, it is basically a central defect, but it's anterior, so we need to come ahead and check. So let's figure out one by one what to do next. So if bilateral, is the defect homonymous? And if homonymous, which side it is what we need to check and is more congruous. So this all applies perfectly for our case 1, because that is a bilateral defect, which is homonymous, and hence applying to this defect, we are getting a left homonymous congruous defect. So in this case, when you have a left superior congruous quadrant anopia, which I showed you in our earlier slides as an occipital lobe lesion, which can have a bilateral presentation centrally, we need to go back and look at the occipital lobe. So this is an occipital lobe lesion because it's highly congruous and still bilaterally central. So let's understand how is the representation of the occipital lobe. This is a calcarine fissure. This is the superior calcarine cortex. This is the inferior calcarine cortex, and this is the tip of the occipital lobe. And see the representation of this tip, which is at the central area. So if you have a problem with the superior part of this lobe, you will have an inferior issue in the field defect. So a left superior congruous central quadrant anopia, which is therefore a problem due to a tip of the occipital lobe. And for this, which is left superior congruous, we are looking at a defect which will be in the right inferior calcarine cortex. So keeping that in mind, we advise an MRI scan, and what we notice here, a multiple enhancing lesions which are seen, which are ring-like ring in the right occipital lobe with perilesional edema, and this patient was already on treatment on TB, was basically more like a tubercular cause. This is basically cyst and was diagnosed as CNS TB. Coming to our case 1, we know this is a central anterior chiasmal lesion. So what it is, it's a left eye superonasal central defect. So we have to go carefully and go back and see to our optic nerve again. So if you look carefully here, you will notice that this is actually an inferotemporal nerve fiber layer defect, suggestive of glaucoma. This patient had normal IOPs and hence was diagnosed as an NTB. So what I would like to end by saying that these are certain cases where if you would have done rightly, picked up cases that there is a problem, do the appropriate field test, and once you get the field test, try applying these 6 questions, you will be able to attain and get your answers. But remember, all this has to have a good and a reliably done field test, a good ophthalmologically done examination, and a good MRI scan to help achieve the proper diagnosis and thereby treat appropriately. Thank you.